Hi, everybody. My name is Anne-Marie Hayes, and I'm a research associate for the Joplin campus of KCU. Thank you for being here today for our Student-Led Journal Club. I will be introducing our speaker, student Dr. Grace Thiel, who is also an anatomy fellow. Today, she's going to be talking to us about her cadaveric study. So to introduce our speaker, student Dr. Grace Thiel is currently an anatomy fellow between her second and third year of medical school. Grace attended Baylor University for an undergraduate degree in health sciences studies. A diagnosis of juvenile osteoporosis first gave Grace exposure to the field of orthopedics. The exposure has continued over the years due to her involvement with sports. Looking toward the future, Grace looks forward to gaining more clinical experience, particularly in the field of orthopedics. And outside of school, Grace enjoys spending time with her family and watching sports. So with that, the floor is yours, student Dr. Thiel.
Thank you very much. So today I'm going to just give a brief presentation on a study that I've been working on with some colleagues entitled Assessing Proximal Humerus Cortical Bone Thickness for Reverse Total Shoulder Arthroscopy. And like Anna Marie said, this is a cadaveric study. So to start off with my introduction, I'm mainly going to be focusing on the clinical relevance of the study with a little bit of introduction to the anatomy pertaining to our study, and then also including the main objective or goal of the study. So to start off, an anatomic total shoulder arthroscopy, which arthroscopy is another word for joint replacement surgery, has been a traditional procedure to perform for a shoulder replacement. Patients who typically need this procedure have some sort of arthritis, typically osteoarthritis, and this has failed physical therapy or joint injections in order to qualify for this procedure. It has been around since around the 1970s when Dr. Charles Neer first introduced it, and I thought I would include this fact because in first and second year we learn about the Neer test, which is a test that assesses for shoulder impingement, and so that's just the namesake for that. I thought was a good fun note. It has changed for the better, as we can anticipate and expect as technology has advanced accordingly since the 70s. So I mentioned that this is an anatomic procedure. So just to reiterate, the anatomic orientation is maintained in this procedure. So the humeral head is located here. This is a normal shoulder anatomy here. And then this is the device over here. And I apologize, my mouse does not line up with what you see on your screen versus what I see on mine. So bear with me as I move it around slowly. So like I was saying, the anatomic location of the humeral head is maintained in this procedure, hence the name anatomic total shoulder arthroscopy. However, this procedure does not come without its own limitations. It requires an intact and functional ability of the rotator cuff muscles, and it also has limited applicability to patients who have severe proximal humerus fractures, and proximal is just meaning closest to that joint. So at the upper portion of the upper extremity, or bone loss to either the glenoid, which is the part of the shoulder blade, or the scapula, and the proximal humerus itself. So in order to combat these difficulties, a reverse total shoulder arthroscopy was created. This procedure is an alternative for these patients who might not qualify for the anatomic version of this procedure. And it has become more common due to its flexibility in treating a variety of presentations. And numerous studies have reported a lower complication rate for the reverse version compared to the anatomic. It importantly only relies on an intact deltoid muscle, so it can be performed if rotator cuff muscles are not intact or functional. So here is an image of that procedure. So as if you recall, the humeral head location is flipped. So where the glenoid cavity, which is the area that is here, it now has what would have been the humeral head, and it's called the glenoid sphere. And then the other areas here, this is the plate version of the stem. So it was mentioned that bone loss can be an indication for this procedure, but how much is too much and how does this impact the procedure itself? So as you can hopefully imagine, the humeral head is removed via an osteotomy, which is another word for removing of that portion of the bone. The area is then reamed, which you can see in this little portion here, and that is to remove the cancellous bone until you reach the cortical rim, which on the next slide, I will have a better picture that shows these aspects of the bone. And so the loss of bone is referring to the cortical rim. And so during this procedure, like I said, the shaft is reamed to that rim, but the amount of bone loss impacts what device can be used. So the device meaning this kind of stem. So what hardware the patient ends up getting. And if the correct hardware is not used, you can get complications such as loosening of these implanted devices. So how do we currently measure this thickness? A thumb test is what's used, and it sounds a little bit obscure, and it's basically just the surgeon places their thumb on the cut surface of the proximal humerus. So this is an image over here on the bottom right of your screen from our study methods, but I just wanted to include it to show this is the cut surface, and the surgeon would just take their thumb and place it in this area here. And so what they do is they describe how the quality of the bone based on how easily their thumb can make an indentation in this bone. And a study was just published less than a month ago that assessed the accuracy of the thumb test compared to CT analysis of the cortical bone. And in their methods, they described the thumb test as two different ways. The bone is either compressed with minimal force, and that had a negative thumb test, or poor bone quality. Conversely, bone that could not be compressed with minimal force was considered to have a positive thumb test, or was known as good bone. So they found poor linking to the assessment of the surgeon thumb tests compared to what they measured in terms of bone quality on a CT exam. And as you can imagine, the thumb test clearly is user dependent. Every surgeon is going to have a different interpretation and use different forces. And it's also experience based. As someone who's performed lots of thumb tests or joint replacements is better, or is more likely to have a better understanding of how easily that bone is compressed compared to others. We also have come across no clear study that has assessed cortical bone thickness just by itself. So to us, this was interesting as it clearly relates to the implant devices that are used per procedure. So we wanted to look at that. And then while we were compiling some background information on this study, we came across two articles, both funded by Exactech, and they're both looking at the same device. And this was an indentation probe, and its goal is to replace the thumb test and provide an objective measurement of the bone quality compared to the subjective version of the thumb test. And this device is currently up for FDA approval to be used in surgery. And these studies were just looking at the usability of this. So once we read this, we were like, this is a really cool device. And we wanted to try to use this in our methods in assessing the cortical bone rim. So moving on to just some overall anatomy, I've talked a little bit about the anatomy of the shoulder, but make sure my mouse is correct. This is the humeral head here and here. The glenoid is right here, and that is a part of the scapula right here. I mentioned briefly about the rotator cuff muscles. An important one for shoulder replacements and just shoulder injuries overall is the supraspinatus muscle. which is right here. And this muscle is important because if someone has a rotator cuff issue, it's likely that the supraspinatus is impacted in this. And if the supraspinatus is not intact, the humeral head can migrate upwards or superiorly in this joint space, and that can further impinge on the supraspinatus muscle. And if this progresses too far, this affects if a rotator cuff surgery can be performed or if they have to have a shoulder replacement. Further, someone can have acromioclavicular or AC joint dysfunction, and that joint is, let me get my mouse, right here. If this area is inflamed, that can further put strain on that muscle. So if this muscle is not intact, then likely a reverse total shoulder arthroscopy is performed. And I described how the deltoid muscle is then used as the fulcrum for that procedure, and the deltoid is right here. Right. So moving on to the methods of the study. We performed an osteotomy of the right humeral head on 45 cadavers. And we chose to just do this on the right because we were not able to have complete knowledge of if the donors were either right or left-handed. So we wanted to help eliminate this and only look at one side, regardless of handedness. The average age of the population was 74, and it's important to note that research on the study, or not the study, excuse me, on shoulder replacements just in general, the average age is around 70 for people who get this procedure. Different sources report different averages, generally between 60 to 80. Some sources cited 70, some cited 72, but our average age was pretty close to that. So this is pretty applicable to what we intend to look at and assess. There were 26 males and 19 females, a part of this population. Upon osteotomy, if any osteophytes or bony enlargements were present around the resection, they were removed with Rongiers. So I wanted to include a picture that we pulled from one of the previously mentioned publications on this indentation probe. This is an exploded view of this probe. So it demonstrates all of the components, but notable the spring here and the tip used can be changed. So we had a conversation with Exactech designers and the engineers a part of these studies before we started conducting our study, and they suggested that we use the smallest force in a spring to start with, and then also the widest base of tip. So we used the radius cylinder. We incorporated this over the flat cylinder because it had a little bit rounder end. We thought that that would be more accommodating for the bone. And then, like I said, we started with the smallest force of spring that we were provided. And we were provided this device through the engineers that were a part of these studies. We were talking with them and they had 3D printed a device and were willing to supply us with the device that they used for their testing purposes. So we used the testing probe to assess the cortical bone rim in 4 locations: the anterior, lateral, posterior, and medial. So again, here is the cut surface of the proximal humerus and the indentation probe that we actually had in possession. So here's the probe we used, and the tip is shown here as well. The spring is inside this white plastic shaft. So in order to ensure that we were using the same force for every testing, the plunger would be pulled out as far back as we could, and then it was used to the same force in every time due to maximal spring loading. We started with the lowest jewel of spring and then worked our way up accordingly. Each indentation was a different number depending on the specimen. That was just because we wanted to make sure we had the most visible indentations on the cortical bone as possible so we could get the best measurement possible. So I don't know if you can clearly see these, but we tried to make indentations working our way out until we could no longer make an indentation. And this is in the cancellous bone. So we're working our way to the cortical rim, and you can kind of visualize the cortical rim more clearly up here, but we did not go off of the visual changes. We went off of where the indentation probe could no longer make an indent in the bone itself. And we measured that with a caliper. So here are the forces of the springs that we used. And like I previously mentioned, we worked our way up in force as needed for testing purposes, depending on the donor. So for our statistical analysis, we used linear regressions, independent sample two-tailed t-tests, and Mann-Whitney U-tests. And I will describe these accordingly further in the results and discussion section. So to start off, again, here's the same picture of the cut surface of the humerus, and this is just placed with the orientation. So here's the lateral location, medial is down here, and as you can see kind of in the background, the rest of the humerus is down here, and the elbow is near the bottom of the screen. The posterior location is to the right of your screen, and the anterior is to the left of this image. In this chart, table just lists the mean measurements in millimeters per anatomic location. And I will say anatomic location for the next few slides, and that's just referring to the anterior, lateral, posterior, and medial aspects of the cut surface. Notably, the lateral position was the thickest overall, like in mean measurement, and the posterior was the smallest. So here we conducted a linear regression, and this was assessing the relationship between the cortical bone thickness and anatomic locations. So we compared two of the locations to each other. The orientation of these does not matter. So anterior to lateral is also the same as lateral to anterior. All of these were insignificant except for the anterior to medial and posterior to medial comparisons. Next, we conducted independent sample two-tailed t-test, which assessed the relationship between the anatomic location and a few different metrics. These included age at or above 60 or below 60, sex, if they had osteoporosis, a known diagnosis of osteoporosis, and a known diagnosis of cancer. All of these were insignificant except for the comparison of age at or above or below 60 compared to posterior location. I thought it was interesting that sex did not have any significant findings. Typically, women are considered to have lower bone density and therefore also would qualify as osteoporosis or could have osteopenia. And we kind of thought that this would have impacted the cortical rim. We did notably only have a osteoporosis population of 2 donors, so this could be findings due to limited data. The known cancer diagnosis population also did not have any significant findings, and I thought this was interesting as well because I would have thought that either chemotherapy or radiation could have impacted the cortical bone quality. This is another independent sample t-test assessing the relationship between the cortical bone thickness based on the anatomic location and the spring used. So we had a comparison run between just the lowest force of spring or if another spring was needed. Notably, almost all of them, or a majority, probably 80%, only needed the weakest spring. But if a higher spring was needed, that did not impact the findings of the cortical bone rim thickness according to these results. So next we have a results table that talked about Mann-Whitney U test, which was conducted for the comparison of sex, and then the rest were independent sample t-tests. And these were compared, these metrics compared to the spring used. All were insignificant here. So for our conclusions, in our cohort, age was found to only have an impact on the posterior aspect of the cortical bone rim. Don't really know what to take from this, but I thought it was an interesting finding. Interestingly, the cortical bone thickness was not impacted by sex, a diagnosis of osteoporosis, or a diagnosis of cancer. And as I previously mentioned, I anticipated that it would be. Differences in cortical bone thickness were also found in regards to both the medial to anterior and medial to posterior comparisons. So my takeaway from this is that multiple locations need to be assessed when you're assessing the cortical bone thickness when deciding or deciphering what implant device should be used per that patient. So currently the thumb test really is only used in one location. And as I've said, it's a pretty subjective measurement to begin with. So if this device is approved by the FDA, it just might suggest that multiple testing locations should be conducted to have a better appreciation and understanding of the bone quality throughout. Our study did not come without its own limitations. Our sample size was pretty good with 45 donors, but it can always be improved upon, and especially in regards to the population with a known diagnosis of osteoporosis. We did have incomplete medical records, so it's likely that we had donors that did have a diagnosis of osteoporosis or cancer that was not included in their chart, or it's also just as likely possible that they did not know that they had osteoporosis or cancer, and therefore we wouldn't have known either. So future directions, we think that this tool could be compared to the traditional thumb test, although the study published a little less than a month ago found the thumb test not to be the best when compared to CT. So whether that's truly applicable, I'm not sure. We had considered doing this comparison, but we thought it would be riddled with room for error just because it's so subjective. And also we did not know the handedness of the patients, which could have further impacted our findings. So based on that previous study, we also think that CTs or MRIs could be used to assess the cortical bone thickness in a lot larger population of people. But it would be important to get the plane of the osteotomy correct in this assessment. And I think that that could be difficult to do, but I'm sure it is possible. Finally, I just want to end with some acknowledgements. I really want to thank Dr. Sloan, Dr. Ollinger, and Dr. Dennis. The anatomy faculty on the KC campus has certainly helped me a lot throughout this year. I also want to thank Felicia. If you do not know, she runs the Gift Body program, and without her, research like this really would not be possible because we wouldn't have donors to work with. So really appreciate the work that she does. I also want to thank the donors themselves as well as their families for the opportunity to learn from them and to learn from their loved ones. I want to thank Dr. Boyne, who helped me come up with the concept of this project, and he also put me in contact with the resident that I'm working with. And finally, I want to thank Dr. Reeves and Dr. Langhor, both of whom have supported my efforts, and they are the engineers who have supplied me with this device. Here are my references. Any questions?
Great presentation, student Dr. Thiel. Super articulate. You did an amazing job. Thank you again for presenting. As she just said, if anyone has any questions, feel free to raise your hand in Zoom or go ahead and just unmute, ask away. You can also type them in the chat. Looks like we have a couple questions. I'm just going to go in order. Dr. Martin.
Thank you. It was a nice presentation, Grace. But my question is, if you're repeating the impact in the same location, you're going to damage the trabeculae with the first initial impact. So how can you be sure that this test is going to be accurate? Because once the trabeculae are damaged in that area, it's going to be a lot softer and you're not going to get the same initial reading.
So that's a good point. We were not assessing the trabeculae themselves. We were assessing where that ends. So the cortical bone should not have been impacted, and to our knowledge, it wasn't. When we were using the testing device on that bone, it was very clear when the probe would hit a spot that it was not strong enough to make an indentation on. So that is a possibility that we did go a little bit farther, but to our knowledge, it's just a different bone matrix. I don't know if you have further follow-up on that or not.
If you'd done microscopic analysis, you would see that there are trabeculae in the area you were using, and they would have been damaged with the impact of each one with those. I know it's difficult to get histology done, and it's very expensive, especially when you get bone and have to have it decalcified, et cetera, et cetera. But it's one of those things that you probably should move to a slightly different area to make sure that you were in a fresh area. That would just be my recommendation for any further testing.
Okay, that's a good note. Another consideration that we had is we wanted to make sure that this was totally applicable to a surgical procedure, and you're not going to send off or have time to send off for histology, and you want to be able to make this assessment in surgery. And so it doesn't have to be like totally, absolutely 100% accurate in terms of the exact millimeter, but just to get a better idea of how thick that bone is.
Now, the comment for the histology was just that you could have tracked how much damage there was to the trabeculae to know if repeated hits in the same area caused a difference or not. But okay. No, you would not ever do that during surgery. They don't have time.
Yeah, that's a good note. Thank you.
Dr. Dobson.
Hey, thanks, Grace. Great presentation. A question. Cortical bone thickness based on ethnicity. What were the ethnicities of the subjects that you had? And would you like to comment about how this would be applicable to the Black population, since they don't undergo shoulder arthroplasty nearly as frequently as whites do?
That's a good point. We did not consider ethnicity in our assessments, and I don't know if we have access to it at this point, since all of the dissections have been completed. I don't know if it's indicated anywhere on the chart, but I can certainly look, because that is a good point.
Be a neat follow-up for you if this process continues to see, because I think probably 90% of shoulder arthroplasties are done on Caucasian people. It'd be interesting to see how the thumb test or this appliance works in the Black population. Great study.
It's unlikely that there's going to be a large enough sample size of African Americans in the lab at this point. But that's really kind of just a guess. But I think that you're going to have a very small number, and I don't know that that would be enough to actually get something meaningful as a comparison between the two.
Student Dr. Thiel, do you have a question?
Yeah, can you guys hear me? Okay. Okay, I have one question for clarification. So when we're talking about anterior posterior, is lateral like the more superior side? Okay. And then is this the device that they are trying to get used in the clinic or for the surgery? Okay.
Yes.
Then I was wondering, is there a significance for increasing the jewel size in some bone that wasn't able to be squished by the lighter weight?
So, yeah, I think I know what you're meaning. So we couldn't make an indentation in some of the samples using the smallest force. So we
Mhm.
increased the force until we could visualize an indentation in the area. And importantly, there was no difference that we found based off of the force needed in the comparisons, which I think is important because it speaks to the fact that no matter how strong that cancellous bone is, it didn't impact the cortical bone
Mhm.
cortical bone rim in
Mhm.
this population, at least.
Oh, okay. All right. Thank you.
Student Dr. Valdivias.
Hi, Grace. Great job on your presentation, and you did a great job explaining in simple terms. I have two questions. First is, what are the changes in the features of a bone postmortem, and how applicable are the postmortem bones to actual living bone tissue in a patient who would be having the surgery?
So that's a great question. And to my knowledge, it doesn't impact as greatly as other aspects of the body. Maybe Dr. Olinger, Dr. Sloan, some of the other anatomy faculty can better speak to that.
Bone doesn't change a whole lot following preservation. I don't know any studies offhand, but I'm confident we could find something that suggests that that is the case.
Thank you. That was what I was under the impression of too, but wanted to double check.
Cool. And then my second question was, what is the risks of utilizing this device that have been previously discussed or studied that you're aware of?
I don't know if there's any risks. So it hasn't been used on live people yet. It's only been used on sawbones and cadavers, to my knowledge. I don't know where they're at in their stage of FDA approval, if they've started the clinical trials associated with that or not. But when I spoke with them, this would have been in the fall, probably in October. They had not used this on a human yet. Obviously, the 3D printed device that I was provided would not be up to surgical standards since it's like 3D printed plastic. So it would need to be metal to be sterilized for the OR.
That makes sense. Again, good job, and thank you for answering the questions.
Thanks.
I actually just saw it in the chat. It's Dr. Valdivias. Sorry about that. As of Saturday, congrats. Any other questions? This is a great discussion. Well, if not, thank you so much again, Student Dr. Thiel. Thank you everyone for being here today. Again, great discussions and amazing presentation. You did a wonderful job.
Thank you, everyone.